lot of radio talk.
Sorry.
Sorry. I have done a lot of radio talks to increase awareness, especially in women. But now, with the RP settling in, started to look into more into South Asians, and I myself was quite surprised as to how much prone we are to having trouble in our ethnic population. And I must be honest, the fact that all of my cardiovascular training has been in the United States, there's a lot more focus on Caucasian population or the white people rather than in the South Asians. And before me digging into this topic, my knowledge about heart trouble in South Asians is also not that good. And with this, I feel like it's very important for us to start this platform of awareness of heart disease in our Asian population. And I would like to start off this talk with a little bit of background as to why we think it's important. Why do we even need to consider our ethnic population as separately from white disease? And then slowly talk on to some risk factors that make us more prone to have heart trouble. And at the end of the talk, I would like to end and see what can be done from our standpoint, or what we need to learn from our standpoint to decrease our risk of heart disease in the future. At any time, please try and interrupt me. This is my first time giving talk to non-physicians. And if at any point you don't understand, please feel free to interrupt me. So I'm happy to answer the questions in a non-scientific way. All right. I do feel our cardiovascular disease in South Asians is a big battle. And it is a battle that's important to fight and worth fighting. And we do have to fight as a community altogether, just not as a physicians. With that, I'm going to go forward. I don't have any disclosures. I'm not affiliated with any finances. So I love this picture. I like the iceberg where there is only a small portion that you see on the top of the sea, but there's a lot underneath it that we don't know. And that's kind of what it is when it comes to heart disease in South Asians. We do feel like we know a lot, but there is so much that we do not know. And like I wrote down here, South Asians is actually a big population involving different ethnic subgroups from a big Indian subcontinent, which includes a large geographic area, including India, Pakistan, Nepal, and Sri Lanka, and Bangladesh. We contribute to about at least 1/5 of the global population. And we are about 3.5 million in the US. And I believe this number is kind of outdated. I believe this number is a little bit more. If we do the recalculation within the recent years, we are probably close to 4 million and at least a 1 million of South Asians in the Canada. So this is exactly why it's very important for us to incorporate our ethnicity in the research studies going forward to understand the risk of heart disease in our population. So there are a lot of studies dating back from 1998 that looked into South Asians and incidence of heart disease, either heart attack or stents or dying from the heart disease. And it shows that we are at least 3 to 5 fold increase compared to other ethnic groups. When we say other ethnic groups, we're talking about the white men, we're talking about Chinese, we're talking about Europeans. So those are the most common groups that are compared to, and compared to all of them, we are at increased risk of having a heart disease. Not only that, we are also at increased risk of heart disease at a younger age. And we also noted in some studies, and again, these are studies that are dated back in 1990s and early 2000s, but for whatever reason, our ethnic background population do not seek medical care as soon as they need to. They often present to the hospital late in the course of their heart attack or late after the onset of the symptoms. The reason for this is quite unknown. I do not know if there are some cultural factors that play a role into this, but we've noted that the time they present to the hospital from the symptom onset is way later when we compare to other white population. Not only that, we've noted that when a patient had a heart attack and we look at the heart arteries, we see that our Asian population have blockages in more than one artery, or either our arteries are much smaller, and which makes treatment more complex and difficult. So this is a very good study, and this is basically a database in United Kingdom. What is a database? A database is something that they take volunteers from the general population, and they collect different data. They collect your height, your weight, your age, your race, your ethnicity. They collect whether you're hypertensive, you have high blood pressure or diabetes, high cholesterol. They collect all that and they follow you over a period of number of years. They don't do anything. They don't treat you. They don't give you any medicines. They don't do anything. All they're doing is every year they collect certain information from you. And if you look at this graph over here, this is this UK database. What they followed multiple people over a period of 12 years, and what they looked on the horizontal line, which we call the x-axis, so that is the number of years that the patient population are followed. They're followed for over 12 years. And on the y-axis, when you look, it is the axis where they're looking at how many people over this period of 12 years developed some form of heart disease, whether it's a heart attack or whether you had bypass or whether you had a stent. So that's what they looked at. And the blue line is actually representing the European population, or in other words, the white people from UK. And the red line is representing our South Asian population based in UK. And you can see the wide gap, and you can see it's going higher up, showing that the incidence of heart disease is way higher in South Asian population as compared to those European populations that are living in the UK. So this is another study. This is actually very recently published in last year. And this again is the same thing. They followed over a number of years and they looked at different risk factors and between different ethnic population. So if you look at it on the top, CAD means coronary artery disease, meaning anybody with a known history of heart attack or known history of stents or known history of bypass. Those is pretty very high in the South Asian population. You can see this is 11% prevalence as opposed to 8, 7, and 6% or 5% in the other ethnic groups. At the same time, I would like to bring your attention to your diabetes. It is also very much significantly prevalent in the South Asians. You can also see the metabolic syndrome, which is also higher in both Hispanics and the South Asians. And if you come down further, which is a high ApoB-A1 ratio, and this is basically a blood marker that we look at, and you can see that is very high in South Asians, predicting our risk for increasing cardiovascular risk. And very important, please let us bring our attention to our diabetes. We are very much prone to having higher incidence of diabetes. And we all know from our traditional risk factors, having diabetes puts you at increased risk of having heart trouble. And that could explain some of the reasons why our South Asians are more prone to having heart disease. So this is again another study called the SHARE study, which is done in Canadian population. And so these are all subgroups in the Canada. They took around 3 different cities in Canada. And what they did was they randomly picked up a telephone directory and randomly selected people. So these are people like you and me and who are just going out on their business, and asked them if they're interested to participate in the study. And they collected a few number of people and they called them and they got their blood work and they also got their clinical data. When we say clinical data, looking into high blood pressure, diabetes, history of heart attacks. And then they categorized them based on their ethnicity. And they followed them over a period of years. And what they noted that even South Asians living in Canada are still at increased risk of having heart attacks or silent heart attacks or bypass surgery. So it's important to note that no matter where you live, the environmental factors are not the only ones that are playing a role, but your South Asian ethnicity, just your ethnic background, where you're from, puts you at increased risk of having a heart disease. All right, don't get scared with this busy slide here. On the left side, I'm just showing a graphic representation of your traditional risk factors. And on the right side is, oops, I'm sorry. On the right side is what we call a inter-heart study. And all of cardiology is based on studies. It's proven data. So it's, although I'm talking to the general public, I believe this is very important for me to show it out there. So what this study is basically looked at is we all know there are some traditional risk factors that increase our risk of having heart disease, like high blood pressure, diabetes, poor diet, alcohol, less exercise, a lot of physical stress, smoking. So these are all called traditional risk factors. And what they did in this study is they looked at different countries along with South Asia, and they studied all these risk factors, and they wanted to see if there is any difference in different countries and in South Asians that would kind of explain different incidences in the risk of heart disease. But if you look at it, like pretty much every traditional risk factor is only slightly different when compared to other countries and South Asians. Like your hypertension, actually it's lower in the South Asians. Your diabetes, it's slightly lower compared to other countries. Your alcohol intake, it's actually negative. So we don't do much alcohol as other countries. We eat a lot of fruits and vegetables, which is supposed to be healthy. So even though these traditional risk factors are pretty much the same as compared to other white population or Europeans or Chinese, why is it that our South Asians still tend to have higher risk of heart disease? And I think that's what is important for us to break down and to understand and to be able to help our South Asian ethnicity in the future and maybe even develop ethnic targeted treatments so this decreases our risk of heart disease in the future. And again, the question why is a big question. So if you look at this slide, the center circle basically is telling atherosclerotic cardiovascular disease in South Asians, meaning that risk of heart disease in South Asians. And if you look on the right side, the classic risk factors, these are always there, but there are other factors that are contributing to that increased risk of having heart disease in the South Asians. And some of them is metabolic syndrome, which I'm going to go into a little bit detail that so you guys can understand and know your own risk factors as well. The other thing is interesting is the visceral adiposity. What does that visceral adiposity mean? Basically fat collection, not just underneath your skin, but around your organs, like your liver, like your heart, like in between your muscle fibers, in your stomach, around your small intestine. So how much amount of fat you have also is important to decrease your risk of heart disease or predict your heart disease. And then this NAFLD is basically non-alcoholic fatty liver disease. What it means, having liver problems or fat deposits in the liver, although you're not an alcoholic, that is also puts you at an increased risk for heart disease. And then genetics are just our South Asian ethnicity genetics. And then our cholesterol, just not how high or how low your cholesterol, but also the type of cholesterol also plays an important role in heart disease. And we'll talk into that a little bit as well. Okay, so we all know our cholesterol. So we have different types of cholesterol, the total cholesterol, the LDL, which is your bad cholesterol, the HDL, which is the good cholesterol. So the bad cholesterol is bad for your heart, the good cholesterol is good for your heart, and then there are triglycerides. So the common, normally for any white man over here, if your bad cholesterol is under good control and your good cholesterol is normal, then you're good. But does the same concept apply to our South Asians? Does it mean that having good low bad cholesterol and high good cholesterol is sufficient for us? Let's look into that a little bit more. So this is a really good study. And look at this. This study is published back in 1999, like way before even we started looking into um, heart disease as an increased risk factor in our South Asians. So not only the levels of HDL or LDL, which is your bad and your good cholesterol, is important, but also the size is extremely important. So this is a good study. So if you look at this graph on the right here, this is our Asian Indian men. They looked at mainly men, and then Framingham men. Framingham men is basically white men from the US population. And your HDL levels, 41 is actually pretty good. Anything above 40 in men is normal. So if you're just looking at the HDL, it's normal. And both Asian Indian men and white men have the same HDL levels. But if you break them down, they're different sizes. So if there are large HDL and there's a small HDL. So if you break them down, the large HDL is actually lower among Indians and the small HDL is actually higher among Indians. Why is this important? The small HDL is actually what does the HDL do? The HDL, what it does is it catches all the cholesterol that is circulating in the blood and actually brings it back to the liver and excretes it out. But, oh, I'm sorry, I think it went back. Okay, so, but even in the HDL, the particle, the size of the HDL is important. The large HDL is actually the good one, which brings back the cholesterol to the liver and keeps it away from the bloodstream and keeps it away from your arteries. But then the small HDL is the one which doesn't do as much as it's supposed to do. Unfortunately, our Indian population have higher concentrations of small HDL, which does not do the adequate job of taking away the cholesterol from the blood and decreasing your risk of heart disease, thereby making you to be more prone to have heart disease. So likewise, LDL too. So the type of LDL or the size of LDL also matters. So in Indian population, the smaller LDLs are in more higher number than the larger LDL. The smaller LDL has a very it likes your bloodstream and it likes the lining of the bloodstream and likes to get stuck to it, thereby making it to more plaque buildup and thereby increasing your risk of heart disease. What do we do with this all this information? Thus far, we only know the information. But like I said, I think it's important to know this information to be able to bring more targeted treatments to decrease the risk and to be able to target those particular factors in our South Asians. And I think right now we are still in the understanding phase of knowing what makes us more prone. And hopefully in the next decade or so, we will be able to come with more targeted treatments to help treat these specifically. Okay, like I said, I was going to talk to you guys a little bit about metabolic syndrome, and I think this is important. This can be very much self-measured at home, along with some help from your primary care physician. I'm sorry. Okay, sorry. So the metabolic syndrome, the main thing that we look at is your central obesity. So what is central obesity? You just basically take a piece of tape and wrap it around your waist at the level of your belly button and measure how many centimeters it is. So I like to draw your attention to the South Asians here because each ethnic group has a different cutoff as to what is good for you. So, and that defines your central obesity. So in South Asians, in men, it has to be greater than 90 centimeters or equal or greater than 90 centimeters. And in females, it has to be greater than or equal to 80 centimeters. So if you have this, you qualify as having central obesity. Along with that, if you have either triglyceride levels greater than 150 or low HDL levels, in men, it's considered to be less than 40, and in women, it's considered to be less than 50, and having high blood pressure or having diabetes or pre-diabetes. Having any of these two risk factors along with central obesity puts you in the category of metabolic syndrome. Why is this important? I think it's extremely important because you can be started on a medication, something called metformin, if you have this metabolic syndrome, that can actually reduce your risk of having a future cardiovascular disease. Metabolic syndrome itself is known to be associated with increased risk of cardiovascular disease. So if you do have these and go back and look at your blood levels and measure your central obesity, please go back and talk to your primary care physician and see if you would be one of those that would qualify to be on metformin to decrease the risk of heart disease. So this is little very basic, and I'm not going to go into in detail depth about it, but I think it is important for us to understand because this will help us know or understand a little bit better as one of the important risks that put us as more prone to having heart disease. So if you look at in the red box here, all of these are basically markers for inflammation in your blood. So these, having high levels of these puts you at increased risk of having heart disease, which is on the right side of the screen here. And then the blue thing here, which is called the adiponectin, which is actually something that you find in your fat tissue. It is actually very protective of heart disease. It protects you from having heart disease. And this particular type of adiponectin is affected if you have insulin resistance. So if you have insulin resistance, it decreases your levels of this adiponectin, which in turn increases your levels of these markers of inflammation, which in turn puts you at risk of having heart disease. And this is important. We'll talk about, keep this in mind. We'll talk about this going forward in the future slides, because this could explain why we are at more prone to having heart disease. So from there, I'm going to switch gears. This is all the basic data that I was able to collect and kind of like lay a platform to look into a bigger study, a need for a bigger study to understand and to at least help advocate for our South Asians to be looked into differently, to be involved into the guidelines. So this is a beautiful study being conducted by one of our very own second generation Indians from UCSF in San Francisco and in Chicago. It is called the MASALA study. So MASALA is an acronym for mediators of atherosclerosis. What it means, the factors that that increase your risk of heart disease in South Asians living in America. So from now on, whatever I'm going to show in this data is the data that we've collected so far in the metabolic study to understand our risk in heart disease. So when any study that we do, we want to set a goal. What do we want to learn from this study, right? So that's kind of, you know, when you're studying for an exam or something, you want a goal. What do you want a goal? My goal is to get greater than 900 or something like that. So any study that we do in our medicine, we need to set a goal as to what we're looking for. So the goal of the MASALA study, and remember this is very important, because the initial step to understanding anything is understanding why is it happening the way it is happening. And once we know why is it is happening the way it's happening, then we can tackle that and deal and create treatments and succeed in these treatments. So in this MASALA study, basically they're looking to see, are there any traditional factors? Are there any cultural factors? Are there any economic factors? Are there any social factors, or some other new risk factors other than the traditional risk factors that make us prone to have more heart disease? And what they did in this study is the way they designed the study, and doing just study in our ethnic population is just not going to help. We have to compare it with other ethnic groups to be able to understand and see, are we more prone to have a more heart disease because of this particular social factor. And that's why when they designed the study, they designed in such a way to mimic something called MESA study. It's another study that is looking into heart disease based on the ethnic backgrounds. And the ethnic backgrounds, the MESA study that we're looking into is the white, African American, Hispanics. They were Asian, but very like less than 1% Indians. They're predominantly Chinese. So we can call them as a Chinese. So it's important for us because so we can compare both of them and see what risk factors are contributing to our Indians having more prone. So there are a total of 906 participants that participated in the study, and they enrolled it from 2010 to 2013. And the enrollment closed after that. And from 2013 up until now, it's more observation. They're sitting and studying them. They're collecting the data and interviewing them, collecting the blood work and all that kind of stuff. So this is the average age of the populations. As you can see, the average age is 55 throughout in the Masala study, but they range from 40 to 84 years old. And majority of them lived in the US over 10 years. But also majority of them are immigrants. So it's important for us to understand this, because whatever data we have here, we can only apply to the immigrants. We cannot apply to the Asians that have born here. And I think that's a separate study in itself to understand if the Asians that are born here are also at a similarly increased risk like our population, that immigrant population. And what I like about this study is 84% of the study population are Indians. So that is good, because it directly applies to us. And although there are other subgroups, they're very minimal. Majority of us are Indian population. And some of them had lower high grade, but very majority of them are pretty well educated, bachelor degrees and higher. So that's important. Okay, so let's look into this another beautiful study. Don't get too confused. I'm going to direct your attention to the lower graph over here. This is basically what we're looking as a B cell function. So what is B cell? B cell actually helps with how much glucose is in your body, and it controls the glucose levels. And that's what they're looking at, how good of a function of B cells each ethnic population has. And you can see that the South Asians have actually lower levels of B cell function, which means that your glucose is floating freely in your blood, which means your risk of diabetes is higher, which means your risk of heart disease is higher. And up on the top graph is your insulin resistance. And this is another measure that they did to look and to understand. And you can see the insulin resistance is way higher in South Asians compared to white, African American, or Latinos. Again, lower B cell function causes higher insulin resistance, causes higher risk of diabetes, which again puts you at high risk of heart disease and death subsequently. Okay, so this is a new score, and I love for you guys to be aware of it, because I believe you can ask in your annual physical exam to get tested for it to assess your risk of heart disease in the future. So CAC basically means coronary artery calcium score. So what it is basically it's a CAT scan of your heart, and we look at if there is any calcium buildup in the arteries that supply your heart. That is what is basically we're looking at. So there is a certain number, anything above 100, you are prone to be having heart disease or a risk of heart attack in the future. And we want you to get started on aspirin and statin therapy. And that's what we're looking at in this population over here. So both men and women, if you look at it, and let's concentrate on the men first and just look at the red line. So the red line is basically the South Asians and the green line is the white population. So this is again the Masala study. So when they started off, they had 0 calcium levels, and then they followed them over a period of years, and they did interval calcium scores on these people. And you can see that the South Asians have a really steep up graph, very much similar to whites in the amount of calcium that is being built up as they're doing the CT scans over a period of years. And that's very important, because having calcium is basically a sign of inflammation in your heart arteries, and that is also a sign of an increased risk of heart attack. But surprisingly so, not so much in women. Although women tend to have higher compared to other ethnic population, they're not as high as the white women to have the incidence of calcium score. Again, if you're going for an annual physical exam, ask your primary care physicians to get tested for the calcium score. If you have any amount of calcium, it's good to go on aspirin and statin to decrease your risk of heart disease. Again, a busy slide, but I will direct your attention to certain parts of the slide. We talked about the traditional risk factors, and we talked about visceral adiposity. What it means is fat built up in your internal organs and how it can make you at increased risk of having heart disease. So in order to understand, is this really true? Because this is what was proposed. And in order to understand, does this really hold true? Are us having higher body fat concentration puts us at increased risk? They did different types of tests. So I would like you to, and a lot of the times they used a CAT scan to measure this fat capacity. So I would like to bring your attention to, can you see my arrow? Okay. So the on the left side, on the left top corner, there is a total intermuscular fat content. And if you see that, it's way higher in South Asians. And also, if I bring down to the lower graph, the hepatic attenuation, it is basically a marker on the CT scan. The lower the attenuation, the higher the fat content in your liver. And then total lean mass. What is a lean mass? Lean mass is your muscle mass without the body fat. So your intermuscular fat is higher. Your hepatic attenuation is lower, which means your fat in your liver is way higher, and your muscle mass is much lower. So they noted all these, and these again correlate with abnormal fat buildup, which also increases your insulin resistance, which again increases your heart disease. So this is again, supporting the evidence that we have a lot of fat buildup, and this also explains why some of us are extremely lean. We don't have diabetes, we don't have metabolic syndrome, we are lean, but yet we have heart disease. And this can explain some of the reasons why we have heart disease. So it's very important, like having a sedentary lifestyle and watching TV for long hours is directly associated with heart disease. So it's very important to exercise and eat healthy. All right. Going forward, we talked about this good fat, which decreases, the higher levels of which is associated with lower heart disease risk. And you can see that this particular adiponectin is extremely low in South Asians. And then the resistant, which is bad for you, is actually higher in South Asians. So both of this, again, this also is part of your body composition, is also puts you at increased risk of heart disease. So this is where it comes, skinny fat, or what we call thin fat syndrome. So if you look at this graph on the left over here, we are looking at BMI, which is a body mass index. What it is basically your body fat percentage compared to your height and your weight. That is what we are looking at. So traditionally, 24 is actually a good number. You're not even considered to be overweight, BMI of 24. So what they did was they looked as to why even Indians or South Asians who are very thin without the traditional risk factors are at increased risk. And they wanted to see if we need to change that BMI targets to these patients. So if you can look at it on the X graph, which is the horizontal line here, is your BMI, which is 19, 20, 21, 22, and 25. On the Y graph, which is the vertical axis, is your prevalence of heart disease, the percentage of heart disease among different ethnic population. And this dark black line over here where my arrow is pointing, that's the South Asian line. And you can see even at BMI levels of 23, which is traditionally considered to be normal BMI, your risk of heart disease is pretty high. So it's important to understand that normal BMI doesn't necessarily mean you have normal cardiometabolic profile, meaning that you don't have your risk factors or your LDL or your HDL are normal. So it's very important, even if your weight is normal, to go have your cholesterol levels checked. So don't neglect that. So this actually highlights that it doesn't directly correlate with hypertension or high HDL or triglycerides or low HDL. It's very, very important to get these checked and have these risk factors under control to decrease your risk of heart disease, even though you're not overweight and you're still within the normal BMI. Okay, our favorite topic, vegetarian versus non-vegetarian. Most of our Indians are vegetarian, which is a good thing. And they wanted to look into this diet to see if it has any correlation to any heart disease. So let's see. What do you guys think? Do you guys think vegetarians have less heart disease?
Yes.
Yes, actually, there's more and more data that's coming out, but we do want much more data. The vegan actually has even more heart benefits, not the vegetarian. So, vegetarian includes milk products, yogurt, and all that, but the vegan doesn't include any animal products that's cheeses or yogurt or paneer or milk, nothing of that. There's more data coming out saying that it's much more heart healthy. All right, let's look into this. So they broke down this into vegetarian versus non-vegetarian. As you can see, vegetarians are tend to be leaner. Their waist circumference is much lower. Their fasting glucose is lower, although not very significant. Their insulin resistance is much lower. If you're a vegetarian, your risk of insulin resistance is low, so which is good. And then if you come down here, let's see, your visceral fat is lower, your systolic blood pressure, not much change, but your LDL cholesterol, which is your bad cholesterol, is also much lower. So there definitely benefits to being a vegetarian. And the vegetarian fat, the fat that we get from the vegetarian food, is actually healthier fat compared to the non-vegetarian, the chicken fat or the meat fat, which is tends to stick more on your arteries. It's not much healthy. Okay, so I'm going to skip through this because this is again the same thing, reiterating calcium buildup in the heart arteries. As you can see, the deep black line is the South Asians, and it's very much higher in Asian men, almost equivalent to Asian white. I'm sorry, almost equivalent to white men. But for whatever reason, it doesn't exactly replicate in women, but it's still significantly higher. This is the calcium that we look at on the CAT scan. Okay, coming to high blood pressure, this is an interesting find, I thought, that they looked into. This is a busy graph, and I'm going to have you pay attention to the bottom half of the graph here. So the orange shade is basically the number of, or the percentage of people that are untreated for high blood pressure. And the blue is actually very well treated high blood pressure, and there are different types of high blood pressure. So if you can look at it, a lot of the South Asians, for whatever reason, have not well controlled high blood pressure. And we do know that well controlled high blood pressure is important to decrease your risk of heart disease, because the high blood pressure increases the stress on your arteries, and it increases the risk of inflammation on your arteries. And if you already have a plaque buildup and there's no more stress on your heart, on that plaque, it tears the plaque and it causes the heart attack. So we know all this information. What can we do to decrease our risk of? How can we prevent it or even decrease it? I think prevention is a key. If we can know the gold mine to prevention, that would be great. But I don't think we're there yet. But I do think there are multiple steps that we need to take to decrease the risk. So one is very important to have your risk assessment with your primary care physician. Your annual visit should just not mean to make sure your diabetes, your cholesterol, or everything is under control, but it's also important to talk about your increased risk to see if there are any other tests that they can do to identify you as having high risk of heart problems. Like we talked about calcium scoring, or EKGs are extremely important to get them every year based on your age. And also maybe like a stress test, a regular stress test. So that's very important. And for physicians in the group, I think considering this testing is important. The risk scores, we traditionally do ACC risk score. I'm going to talk about Q risk 3 a little bit more in detail. I do believe it's important to kind of increase the awareness of this risk score amongst the physicians, especially in South Asian ethnicity, so we can identify high risk population much more easily, so we can treat them better, so we can reduce the risk. Lifestyle changes, extremely important. We all know this, cannot reiterate this enough. Uh, these are the risk factors that are in our hands that we can control. Unfortunately, our genetic risk factors are something that are not in our hands and we cannot control. So this is extremely important, what that we can do that is in our hands to decrease of risk of heart disease. Regular exercise is very important, and please remember that exercise doesn't have to mean running or jogging. It can be a brisk walk, it can even be a light swim, it can even be a stroll, but something outside of your normal work, you need to incorporate that. Healthy nutrition, like we talked about, and weight loss if needed. So next, drug therapy. We talked about this. CAT scan, if there is calcium buildup, aspirin and a statin, or having your blood pressure under extremely good control, having your diabetes under good control, very important. And I think it's important for us, and which Dr. Vasudeva has done a great health fair. Like this is part of a health fair, educating our community, and also maybe if we can do some free screening for people, and more education, like maybe set up a health fair where there are um, uh, stalls that people can come to and get them tested, and more information given to them would be beneficial. And next to the higher levels, I think it's very important to have these studies done so we can bring it to the level of uh, our bodies that can make some changes along with insurance to allow us to incorporate South Asian ethnicity as a higher risk. So getting medications or getting special treatments or special testing would not be a hassle going through the insurance approvals. Last but not the least, it is important for our population to participate in these research trials. A lot of the research trials that we do in our in heart disease, less than 1% is Asian. Even like forget about heart disease, the COVID trial, the Pfizer trial, the Moderna vaccine trial, less than 1% is Asian population. I do feel like if we are one fifth of the global population and about 4 to 5 million are living in the US, I do feel like we have to have a higher footprints in these research trials, so when they're doing all these medications and everything, we can know that it is working for us or it is not working for us. So I encourage you guys to participate in more of these research trials so we can have a bigger footprint. So this is for physicians who are in the group. This is a QRISK trial. QRISK.
Excuse me, doctor.
Yes.
Can I interrupt you? I'm Dr. Shibal.
No problem.
You were talking about the trials and non-involvement of the Asian population. We do not come to know about these trials or studies. And maybe that is one reason why the participation is less. So how to get that awareness?
That is so true. I think, and that's where the government bodies and the other higher officials are important to bring their data to their attention that South Indians are at increased risk. So they can, when they are doing these research trials, they can actively reach out to us. And when they reach out to us, we should be willing to participate. And I totally agree that a lot of this is done in the university setting, and most often it is done by physicians like us, like saying, hey, there's a research study, do you want to participate in this? And I think the governing bodies actively, or the research trials actively looking to incorporate more South Asians will actually help, and that's where higher level of involvement is important.
Thank you.
I have a quick question. I need to leave a little early.
Sure.
Can you address quickly about the controversy about the aspirin, preventive use of aspirin, please?
So good question. There's actually no studies that have been done on aspirin to really help in heart disease. And recently there has been a study that showed whether preventive use is even helpful. And it has been shown that it's not helpful in primary prevention of heart disease, in the sense that earlier, if a patient is diabetic, you would put them on aspirin because diabetes is considered to be coronary artery disease equivalent, but it's no longer considered safe or effective to do primary prevention. Secondary prevention, it is proven, but primary prevention, it's not proven anymore.
Oh my God. Thank you so much.
No problem.
Thank you.
Yeah. So moving forward, this is the risk score. This is for physicians in the group. The traditional risk score that we use is the ACC risk score, which less than 1% of participants are South Asians. And there is a nice study that was done in North India who actually took patients who had heart attacks, about 1,000 patients who had heart attacks, and took them one day prior to the heart attack and calculated their risk score. And their risk score was, they're considered to be low risk of having heart attack. About 40% of them fell in the low risk category of having a heart attack, even though they had a heart attack. So the ACC risk score doesn't really help us in categorizing our patients really well. So I recommend primary care physicians or whoever out there, if you're seeing a South Asian, to look for a Q risk 3 calculator, which if you look at it, I know this is not very clear, but there is an ethnicity tab under there. And then if you pull it down, there is a South Asian or there's an Indian tab. And that actually adequately puts us at high risk or low risk or moderate risk, which is important. As you know, ACC recommends if you're at moderate risk to start a low intensity statin, or if you're at high risk to start a high intensity statin. So I think that is very important for the physicians in the group out there. Again, so these are proposed, and this is not by any way guidelines. And this is recently again published in 2021 by the National Lipid Association. What are the guidelines that you want to follow to decrease the risk of heart disease in our South Asian population? You really want to aim for your waist circumference less than 80 in women, less than 90 in men. You do want your body mass index less than 23. That is extremely important. If we look at white men, 23 is normal, but not for us. So we want our body mass index to be, and this is like really, we are like really going to the extreme in treatment. We really want our LDL levels also less than 70. And this is considered to be high risk in high risk patients. And I feel like South Asian ethnicity is itself a high risk. So aiming and targeting to that level to begin with decreases your risk of heart disease a lot. And if you're a diabetic, you want to aim for your A1C to be less than 6 and your triglycerides to be less than 150. So again, a little bit of a data. There's not much data in Indian food as to which is good for heart and which is not good for heart. The only heart healthy diet that has been proven to be good for the heart is the Mediterranean diet. And we Indians are very much Indians. We love our Indian food. We don't want to give up our masalas and all that. I believe we can still do a good, healthy Indian diet, and which includes all those up there that I've listed: whole grains, whole wheat, millets, lot of low fat. You want to go skim milk, low fat paneer, lot of fresh veggies, nuts. Although it's written in this article, almond and peanut, I don't really agree with that, with the peanut part of it. I recommend you guys to stick to almond or walnut. And cook with olive oil, canola oil, or safflower oil. Stick to olive oil. It's pretty expensive, but it is affordable. Olive oil is actually the reason why the Mediterranean diet is shown to have impact on your heart, because they do a lot of olive oil. If we can incorporate that into our Indian cooking, I feel like our heart disease might decrease the risk of your heart disease. And obviously avoid the bad stuff. We all know ghee. I think a misconception: ghee is good. Please try and avoid that. Butter, any coconut products. There's a lot of propaganda right now about a lot of coconut, drink coconut oil, it's good for you. Please avoid them. It's not. Everything in moderation is important. Again, adding salt to foods. We do salt. Salt is needed. It's important for our body. We don't want to do too much salt. Low salt is always good, but don't add salt on your. We are in the southern here, so if we get into the southern habits of adding salt on the watermelon or something, try and avoid that. It's not. Okay, so this is like more a slide to kind of get like higher authorities be involved to decrease and also increase the awareness of heart disease in our South Asians. So we really want to, the first important thing is to educate the medical community. Like I said in the beginning of the talk, even before I started looking into this talk, I was unaware or I was ignorant as to how much of high risk we are. I kind of was aware that we are at high risk, but not as to how much high risk. So it's always important to educate our medical community. And the way we can do that, I believe, is to take it to the higher levels, to our guideline levels, and include South Asian as an increased risk or like a separate risk factor itself. So more attention is paid to our community. And you involve, for the physicians out there, you want to use the Q-risk score and also the calcium buildup in the heart arteries to identify the patients at risk of heart disease and to start treatment early on and risk factor modification early on. And there is, I don't know how many of you are aware, but American Heart Association does something called a Go Red initiative, which is to increase the awareness of heart disease amongst the population, because heart disease is still the #1 killer in the United States. So they really wanted to bring awareness so they can take health in their own hands and get screened and decrease risk factors. I believe something similar initiative, I don't know, maybe Go Savvy Red, maybe something like that, to also increase awareness of heart disease among South Indians would be a good thing to do. Maybe one day in a temple we wear red, and people who are coming to the temple, we tell them, hey, you know, this, we're wearing this because as a South Asian, you're prone to increased risk, and please go get your levels checked. Please be active, be proactive about your health. And then advocate policy change, like we're talking about. Somebody asked me, how do we represent ourselves better in the research trials? So by doing the policy change, going up to the higher levels, we contribute to so much of the population. Please incorporate us. Please, increase the awareness and more participation from our standpoint in the clinical trials. And that is it. Thank you. I'm open for questions, and this is the most information that I have that I can give.
That's an excellent talk and very well presented. And question-wise, you have two options. One thing, you can either type it in the chat line, as several of you have done. And once the chat line we get through, I'm going to stop your slide sharing.
Okay, so
can you stop it yourself?
Yeah, I can.
Okay. Now let me get you a little larger gallery view. Okay, we are in the gallery view, and some of you are already typed in the chat line. Can you read that on the chat line?
You mean in the chat?
In the chat line on the side.
Yeah.
For an Indian woman who is not obese at all, has an active lifestyle, and all of the factors under control, what is the risk of coronary artery disease when only SSR? What do you mean by SSR high?
But only the numbers that are high are LDL cholesterol and the total cholesterol. Again, that's a good question. We really have to plug it into the QRISK-3 data, because it's based on your age, your height, and there are other risk factors that play into role. Just having high cholesterol itself puts you at high risk of having heart disease. So I would recommend definitely getting on treatment for this, for sure. I cannot just say what the percentage is, because it all depends on the individual weight and height and other risk factors that go into it, if I have to give you a percentage. Okay, and I think there's another question saying, what about avocado oil? I wish I can answer that. I don't have any information on that at this point.
So, Dr. Ramya, thank you. Going back to the first question, that was me, Surekha. So that was for me. It was an excellent presentation. So I mean, based on what you said, do I need to talk to my physician or to get the Q3?
Yes. I again, like I said, a lot of physicians are not aware of this risk score as well, and it's easy for you to do it online. Just go ahead and if you know your numbers,
I do.
If you know about LDL, and which most of us do in the current day data, just Google Q risk 3.
Okay.
Okay, and it should, if you plug in there, it should give you your risk percentage for your heart disease.
Okay, that's excellent.
Different factors, and if there are some factors that you don't know, I'm sure you can contact your primary care physician and get those numbers as well.
Okay, thank you so much.
If any other questions, please unmute yourself. All of you are muted. Unmute yourself and ask the question. Any other questions?
Well, that was an excellent talk. Thanks for doing it, Ramya.
Yeah,
it was amazing. Learned a lot again this time, even though you presented at the RP meeting.
Yeah.
I think going forward, Dr. Vasudev does an outstanding job on trying to get the community to learn about this. But you know what? I feel like how you mentioned, like putting this out to the community is so important, because the only way we can do it is at the temple or the Gurdwara or at the Jain temple. And I think that's a great idea, like going like a red salwar, red sari day or something. When the women come to the temple, everyone else get involved, and tying it to the cultural aspect is so important. And I think we have to do something like this. Maybe we can just have charts like a Q3 risk factor score, and maybe have different posters. And in that way, people begin to ask questions. And then in that way, they get inquisitive, they calculate their score, they get more proactive with it.
Yes.
But teaching about like even the food, like any party we go, we have all the foods that we're not supposed to eat. So I think, like what we can do as far as helping the community is trying to increase the awareness, because most of the time people don't have the right guidelines, because they go by what they see on the media about, like how you said, coconut oil, right? So that's what I would suggest, and I'm willing to help in any way to help with putting forward that event.
Now you mentioned about the apathy. That is very true. When we first, of course, we came here almost 50 years ago, and when we arrived here, most of the Indians, they had said, "Hey, we are not going to get critically ill. We are not going to die. We are invincible." Lifestyle was terrible, especially in men. Women were okay. No exercise. The eating habits was terrible with all the fried foods and all, and staying awake till 2 a.m. in the morning playing tin patti. And very few of our Indian friends, even some of them, even at the age of 65, had not had a physical done. But things are getting better. More and more Indians are getting into conscious about the eating habits. They're exercising more and more, which is good. But still, when it comes to controlling your blood pressure and blood sugars, we are still little, as some people are still little slack about that. So that is very important. Both of us, myself and my wife, both of us had several cardiac issues. We had several stents, 2 bypasses, and we have to be extremely careful. As far as the vegan diet, all my life I have been a non-vegetarian. In our home back in India, every day we used to have non-veg food, fish. Then 8 years ago, with all my cardiac problems, I decided to go vegan. And every time we go for any outings, cruise lines, 95% of the food there is non-veg. And I had to resist all that. And my cardiologist was very impressed after 4 or 5 years on vegan. He said, "Hey, Pramod, your arteries are looking better." He himself was not a great proponent of vegan. But then when he saw all that, I'm a little bit slack on that. I'm still vegetarian. Occasionally I'll eat some eggs and all, and some yogurt. But I think that is absolutely true, that vegan and vegetarian diet is good. Second thing is about the fried food. And everybody loves fried food here. But what we learn from our personal experience about 4 or 5 years ago, we decided to invest in an air fryer. Air fryer is a great thing. You still can do your samosas in the air fryer, your fritters in the air fryer without frying. So, and it's pretty handy and very easy for young kids to use the air fryer because everything is on timer. So those are the things. But I think apathy is a big problem. Look at the amount of number of people attending today. We had sent so many emails, 500 emails. We are sending another 700-800 through the temple, and weather is terrible outside. They cannot go out and party. And people cannot just go on logging the Zoom and sit at home. But that is apathy. Uma has some question. Unmute herself.
I have a question.
Hi.
I would rather ask, my family has a risk of heart attack. Everybody just goes by heart attack or stroke. That's my family history from my father's side. But I am, for myself, I'm within the weight limit and I do not have the diabetes. And I have been, I'm a vegetarian. And with other things, I try to follow the rules, but I just found out that I have the heart issues and I do not know the detail of it. It is not an attack, but it is the beginning of it. There are some issues there. So I would request you to give me the food list. I could not copy it down. What I can have, the food list. If please allow me to have it, that would help me a lot.
Ratna, this program is recorded.
Oh, I'm
I will send you a recording, which is actually, I enjoy the recording, cloud recording, because I'm busy with all this administration thing. So the next day, I personally review the cloud recording, which is so clear. So I think I may have your email address. Okay. And I will forward the recording. Very easy to log on the recording. And is it okay, Ramya, for people to listen to your...
Thank you so much. Thank you.
I think there's a question in the chat box saying, does GMO come into play for canola oil? I do not know about that. I'm sorry, I won't be able to answer that question. I think it's Sridevi asking it.
Uma has some question.
Yeah, I mean, I have a very simple question, but I think it's common knowledge.
Sure.
For most of the people, younger individuals actually, that are immigrants, the levels of stress, the stress levels have a lot to contribute. Besides, even if you keep all of these under control, the risk factor seems to be actually twice the amount of, but of course there is stress everywhere. How to handle the stress will become another huge subject, and it's very individualized.
That is,
yeah.
That is so true. That's actually not just the immigrant Asians, but I think our generation in general, I think we are running behind a lot of stuff. There's so much higher expectations from your job, your friends, your relations, everything. I think compared to 30, 40 years ago, the expectations have gone up higher. And I totally agree. Psychological stress is one of the bigger components, and some of the heart attacks that I see happen was patients having an altercation with one of their family members, or one of their family members is going through some stressful situation that they're feeling stressed about, and that puts you into a heart attack. Yes, it's extremely, extremely important. And I agree with you. Dealing with the psychological stress is an individualized thing. And there are a lot of resources out there that can help you walk through the stress. I feel like, for me personally, I feel like developing a hobby that you really love takes you out of your stress. I can tell my personal example. During the COVID times, I was extremely stressed. None of my family is around, and I've heard stories where two physician parents, both of them ended up having COVID, and they had to take their kids and put them in the pediatric hospital because there's no one to take care of them. So my stress levels were significantly higher, and I was stupid. I was like exercising 2 hours a day because that would take my mind away from the stress, and I would work out 2 hours a day. That's actually makes me very happy, help me with the stress. And even now, as busy as I am, I try to take time. I set aside at least 3 to 4 times a week, 1 hour time for myself, and do what I feel makes me happy. Even, no matter how tired I am, I just go and do it. And I feel like, okay, this is time for myself. I feel really relaxed. So it is individualized, and it's a very important topic as well. That is kind of hard to tackle in all together. But yes, that's very important, to find your own ways to relax.
Yeah. And I think specific to our ethnicities, you always want to prove that you are better.
Right, that is so true. That is so
prove
true.
to yourself and to your neighbors.
Yeah, that is so true. The first thing is to know that you are enough. I think that statement, quote unquote, is very important. And making sure you're happy with yourself the way you are, and accepting yourself, is a big step to decreasing the level of stress.
I bought a couple of plaques for friends, and I found it. You are enough. You do enough. Enough.
That's right.
I don't think they will stay my friends for long, but thank you.
Yeah,
Any other questions? Anybody has any? Yeah.
Hello, Dr. Ramya.
Hi.
It was good, very good presentation. This is Chiman Delwadia. It's not question, but just a comment that we used to run that free health fair in Birmingham, Alabama.
Okay.
The problem we were running into the uninsured people, those who don't have insurance, they're reluctant to come to the fair, health fair, because they thought if we knew we have a problem, then where we go? We don't have anywhere to go. So we had a very hard time bringing those people to the health fair, even free health fair, because they didn't want to know that they have a heart problem. So
yeah, agreed.
This is my just observation.
True. No, we've done a health fair over here with Daya Foundation, and we did that health fair not just for the Indians, but I think they also wanted to incorporate the Mexican immigrants, where there are a lot of them, but not a single Mexican immigrant showed up for the exact same reason of fear of exposure. I wonder if there is a way we can put it out in the flyer that, irrespective of your immigrant status, we provide this free, or maybe give them some sort of reassurance. But again, I think we still run into problems with these free health fair, because most often patients or people come and get tested and hoping or anticipation of that we are going to give them the necessary medications and that kind of stuff. And unfortunately, with our health fairs, we can only identify the risk factors. At least the last health fair that we had, that's the issue that we sought out, is that we could not provide them with the medication. Some of them are like people who came from India, staying here for 6 months. They ran out of medications. They were hoping we can give them the medications, that kind of stuff. Those are always hard issues to tackle. I think hard social issues in general to tackle.
How about Good Samaritan clinics? Don't we have many here? I'm still fairly unfamiliar.
Which one?
The Good Samaritan clinics?
Yes, I do not know in Nashville, but we do have in Murfreesboro. We do have like two clinics that are. Yes. One of them is a Hope Clinic, and the other one is actually our St. Louis clinic, affiliated with the St. Thomas, who actually provides free medications and everything for immigrants or the uninsured, irrespective of the immigration status. Yeah, if anybody wants to refer them but they have to live within the county. The Hope Clinic is the county, but the St. Thomas, St. Louis doesn't have to be where you live. It offers free for everything.
Because, we moved from Florida. I volunteered at a Good Samaritan clinic for almost 4 years.
I'm sure
They
there
are
are
very helpful.
Yeah, I think there are in Nashville too. We just need to.
No, there are several of them in
Yes,
Nashville.
I'm sure they are.
There's one more quick sort of comment here. Several of us have multiple cardiac problems like we have, and we had some issues taking the statins. And I tried several statins all my life. And after a year or two, I had to give up, and I was being looked upon by a very well-known lipid doctor at Vanderbilt. So eventually, for the last 2 years, I've been taking this PCSK9 inhibitor. The name is a Repatha, R-E-P-A-T-H-A. It is an injection. Twice a month, I take it. And as you mentioned earlier, high-risk people have to have a LDL of below 70.
That's right.
And first time in my life for the last 2 years, I could have getting my LDL down to 55, 60.
That's awesome.
Which is really a blessing. And I think I told you that during the RP meeting, that this Repatha was a specialty drug, which was very expensive, but starting in January this year, it is taken off the specialty market. So it is available in the regular drugstores. It's still expensive, $400 to $500 a month supply. But some of this good RX and all, and some insurances will cover that.
Most insurances, I think documentation is key. If you are allergic to statin and if your physician you have to document really, really well that you're allergic to all types of statins and you've tried everything and you failed and you're at high risk because of your heart disease and you really need your LDL under good control. Most insurances cover it. We appeal, and it has gotten way better compared to 4 or 5 years ago. I could not get any insurance company approval go through for Repatha or even for Praluent, which is another PCSK9 inhibitor. But now it's so much easier. There's also a new tablet that came out called the Nexletol, which is a non-statin lipid lowering drug, which also has shown promising data. So that drug is out there too. But again, it's still new on the market. So I'm sure it is also expensive. But if we can prove that there is statin allergy, I'm sure the insurance will cover it. But the copay is still going to be around $40, $50.
How do you spell that, Nexletol?
Nexletol.
Nexletol. Okay. Now, talking about baby aspirin, we have always been told, I think one of the participants asked that question to you.
Right.
But there's some controversy about cardiac problems. But as far as CVAs, people with a family history of coronary artery, cerebrovascular disease and all, a lot of these physicians are strictly still recommending daily baby aspirin. What is your comment on that?
So patients who have history of stroke, heart disease, and benefit from baby aspirin. And the other population that we commonly put our patients on baby aspirin are we don't have data on this in here, but there is some European data to support it, is patients who have coronary artery calcium buildup in the heart arteries on the CAT scan. But regularly for primary prevention, like our patients who are diabetics, or patients who have end-stage renal disease, or patients who have significant family history, it's no longer recommended to be on a baby aspirin. The risk of bleeding events is higher, and the benefit is not much. So they're no longer recommending it for primary prevention. It's mainly for secondary prevention.
Dr. Vasudev,
Yes.
This is Dilip Sachan. My video is not working. This is my new computer. I haven't learned to something wrong. But anyway, I do want to make a comment related to the participation by Indian community. And Dr. Ramya, if I am saying that right, you've done a wonderful job. This is one of the rare presentation that brings me up to date on the, I'm an academician more than anything else. So what we have done in our human studies, whenever we did, we had dedicated students that were doing their PhD or master, usually PhD, and they collected data not only in here of Indian community, but also in India. And in those days, we could bring blood samples also without too much of restriction that we have now. And the one trick that I understood from students was that they almost practically went and became like a part of the family. They made 2-3 trips before they could get the families to participate and help them understand. So I'm not saying that it's easy for you to do this. All I would say, don't give up. And to my friends here, that every time you talk about any of the studies, please repeat what is repeated here, that urge them to participate in studies. So more they hear about it, chances are more of them would participate. Thank you.
Thanks, Dilip. Thanks, Dilip. No, that is, Anuradha made a good sort of comment there about getting involved in the temple. Several of you know that we started this health station before the COVID at the temple. There were live sessions. We used to have 3 or 4 rooms upstairs, and I used to select the speakers. And for some reason, the live participation was better. Even for the ICSSS, our Seniors Association, we started 12 years ago. Initially, before the COVID, we used to have live presentation at the Brentwood Library or one of the hotels. And the participation there was much more. There is something about human contact. People want to meet each other, greet each other, and then always we have some snacks we used to do. They used to enjoy that. But for some reason, some people have this total apathy, I would say, and most of them are technically savvy now to log on to Zoom. You just had to just put a click on that and you're in Zoom. But they just had this apathy. So we had to look into all this and see how we can make our community more aware of this, whether a red sari or I don't know, what would you give for the men?
Well,
actually, American Heart Association is actually red. So red represents blood, so that represents heart. So I think a universal red, but with the cultural aspect to it, like a sari or a salwar, definitely. I mean, we can. February is the month, is the heart month, and I think we can pick that to put in some flyers. And I know this is the COVID time. It's I don't think we'll be able to do a lot of people wearing red and like advocating for the heart disease. But hopefully in the future we can use that February month, which is the heart disease awareness month, and do the same for the South Indians in the temples. Kind of mimic what they do over here in the U.S.
Oh, that's a good suggestion. Because hopefully, when this Omicron is getting under control, hopefully in the 3-4 months, we may start the live sessions at the temple, and we may get better participation. Oh, by the way, your friend, this whole recording has been done on the cloud, and if your friends or family, if anybody wants to listen to this was a great presentation. Please send me your emails and I'll forward that link, and it's very easy to log on that. So anyway, yeah, I think Surekha has a question.
And yes, Dr. Vasudev. Dr. Ramya, I actually went online and ran the Curis score. Is it okay to share it here in the forum or?
Quick, okay.
Yeah, it's quick.
You know how to share you know how to share the slides?
No, not the slide, but I can just copy and paste the values here. So I'm not very clear on some of them. So that's the reason why I just wanted to run it by you.
Or you have you put on the chat line there?
Yeah, I put on the chat line.
You're 10 years, okay. Do you want to read that?
So you're 6.3%.
Uh-huh.
Yeah, so that's considered to be low risk.
Okay.
Yeah.
That's good to know. Thank you so much. Because I've gone to my cardiologist, I got all tests done and echoes and everything. So this was actually very helpful. And I mean, your presentation was excellent. And then using this tool and your response has actually helped me a lot. Thank you.
Any other questions? If not, give her a good hand for this excellent presentation. That was great.
Thank you.
By the way, if you have any other suggestions as far as the future topics, please contact me. And we will try to get, we are very lucky now. Most of our speakers are from the Indian community we had, and all excellent speakers. So we are very lucky that we have such a talent in our Indian community. And we don't have to, very rarely we have to go outside. So let me know if you have any suggestions. And again, thanks and have a happy new year and enjoy your new year. Thanks.
Thank you. Happy New Year.
Thank you. Bye-bye.
I'll end the session.